So we're going to go ahead and get started. Thank you, everybody, for coming to our last of the Brain 101 Mini Medical School, hosted by myself. I'm Kevin Lillehei, Chair of the Department of Neurosurgery, and Tammy Lack, who is our Director of Strategic Development and also the Executive Director of the Neuroscience Innovation Initiative. So this is sponsored, obviously, by the University of Colorado and by the Neuroscience Innovation Initiative. Tonight, we have the last, I'll go back, we have the last of our 6 talks. And up to this period of time, we've kind of just started out with the anatomy of the brain. We've discussed different diseases of the brain, but we've always been able to kind of directly relate it to kind of the structure of the brain by MRI scan and the rest. Today is going to be a very interesting talk, and I think it's a great talk to finish with. And that's really an introduction to psychiatry and substance abuse. And this is an area that I think we understand less about. Dr. Hopfer and Dr. Hutchison are going to educate us today and give us a little bit more understanding of how these nebulous diseases really form in the brain. But before we get to that, let me talk a little bit about the Neuroscience Innovation Initiative. That's been one of the reasons that we sponsored this Brain 101 talk. And this is really the precursor to developing a comprehensive neuroscience institute on the campus here at the University of Colorado. And it's dedicated really to integrating all of the neuroscience work that's going along in our campuses over the state and really all the neuroscience research that's going on in the state as a whole. And it's to create a platform for collaboration amongst all the neuroscientists and also to communicate really the incredible science that is going on, not only at the University of Colorado, but again, across the state. And it's kind of our motto is trying to make Colorado the healthiest brain state in the country. So on the left-hand side, you can see that our psychiatric disorders and substance abuse are part of our neurocircuitry program. And I think Dr. Hopper and Dr. Hutchison will talk to us about some of those circuits that we don't understand terribly well. Again, this is our last session. We decided not to do a graduation the following Saturday. I think everybody's busy. It's summertime. So we've gone ahead and canceled that, but we will be sending out people's diplomas. Tammy will be sending out the diplomas. In addition to that, every week she's been sending out a copy of the recordings from our session, as well as any of the answers to the questions that have gone on to the chat line that we didn't have time to answer. So you'll get a communication from Tammy concerning this. Again, during the talks, please use the chat function at the bottom of your screen. Anytime during the talks, go ahead and enter your question. Tammy's going to keep track of those, and in the last 10 minutes or so that we have of the hour, we'll start going through some of those questions. And I've been impressed. The questions have been terrific in all of our sessions. So having said that, I'm going to go ahead and introduce our speakers and then let them go ahead with it. So our topic again is Introduction to Psychiatry and the Brain and Substance Abuse Disorders. Dr. Hopfer will be our first speaker. Dr. Hopfer is a professor of psychiatry with a specialty in substance abuse. He's board certified in both of these areas and operates out of the CU Anschutz Cedar Center. The Cedar Center is a separate institute, separate building on campus. It's a center for dependency, addiction, and rehabilitation. Dr. Hopfer received his medical degree from Case Western Reserve University in Cleveland, Ohio. And his research focuses on genetic and environmental factors that influence the development of substance abuse disorders in adolescents and young adults. He also examines risk factors for HIV and AIDS. He'll be giving us a general overview of psychiatry and the brain, and then we'll hear from Dr. Hutchison, who will give us a more detailed kind of information about substance abuse. Dr. Hutchison is a professor of psychiatry, also at CU CU Anschutz Medical Campus. He has a background in clinical psychology and a focus on clinical neuroscience and cannabinoids. Dr. Hutchison is known for his pioneering research in the area of cannabis and cannabis-related research. He earned his PhD in clinical psychology in 1995 and then completed his postdoctoral work at Brown University in 1998. After that, he came here and initially joined the Boulder campus faculty and then over here to Anschutz. Throughout his career, he's been dedicated to understanding neurobiologic underpinnings of addiction and developing innovative innovations for substance use disorders. He's currently director of the Rocky Mountain Center for Research on Cannabinoids and leads a multidisciplinary team of researchers focused on the effects of cannabinoids on the brain and behavior across the lifespan. He's been NIH funded the last 20 years, and recently served on the National Academy of Science Committee that published a comprehensive report on the health effects of cannabis. And the result of that recently actually testified at 2 congressional briefings on this subject matter. So both of our speakers are really kind of stars in their area. I'm going to go ahead and stop sharing and turn it over to Dr. Hopfer.
Thanks for that introduction. All right, here we go. Let's see if this works. So can you see that? Nod your head.
Yep, that looks good.
So I was asked to give an overview of psychiatry in 20 minutes with a focus on the brain. And I'm going to hit the highlights. It's a very broad field, and I think I'm going to try to emphasize certain key points. And let's see, I don't have any like conflicts. So let's see now. How do I get this to move? Okay, so I thought I'd just really give a brief overview of the history of psychiatry, and because it relates to the current way we conceptualize mental disorders, basically. And I'm also going to emphasize a little bit how psychiatry and neurology have sort of diverged as certain problems or mental problems or behavioral problems. It became clear what the underlying sort of brain pathology was. And then I'm going to kind of move into what are modern like trends and developments in psychiatry. And we're going to stick more to the brain related pieces of it to the extent that I can. Okay. So psychiatry, what it is, it's actually a medical specialty that focuses on disorders of mood, cognition, behavior, perception, and emotion, and their diagnosis, prevention, and treatment. And it does overlap partially with neurology and psychology, but neurology is distinguished more by having more objective brain pathology that's known to cause or be related to the neurological disorder. For example, stroke causes damage to specific brain regions. Epilepsy, which is interesting, nobody really understood it until the development of a new technology that allowed the measurement of brain waves. And then it became clear that there were neurons firing, all simultaneously causing seizure disorders or degenerative diseases such as amyotrophic lateral sclerosis. But back in the past, people were sort of not totally clear on, is this going, what's causing this? And, historically, they were actually a single field. They were called alienists at some point in the United States. But over time, as the brain pathology became more clear, the more objective illnesses sort of moved into neurology. And it's also just worth mentioning, in the early 20th century, many patients in psychiatric institutions suffered from what was like neurosyphilis, which was actually a very common cause of neuropsychiatric disability. But modern psychiatry really traces its roots to Emil Kraepelin, who was a German psychiatrist who was actually a colleague of Alois Alzheimer. And he was trying to figure out what are these behavioral problems he tried to come up with a system of classifying them. And he came up with the first concept of like clustering behaviors. And that's really how psychiatry is organized. It's really based on signs and symptoms which tend to stick together. And he sort of kind of came up with the earliest ideas that, for example, schizophrenia might be an illness of the brain, even though they never really could understand where in the brain the illness was happening. And he was actually a colleague of Alzheimer's, who was sort of, also trying to understand dementias and realized that this was due to a brain pathology, which you could actually see under a microscope. And I think what characterizes psychiatric illnesses is you can't see any pathology under a microscope, but there's obviously something going on in the brain. And this is like the key point about psychiatry. All the illnesses are based on signs and symptoms which cluster together. And it differs from other medical fields, because most of medicine bases its disorders based upon a known pathology, or at least, and the reason, however, psychiatry doesn't do it is because they don't know what the pathology is. But for example, depression is characterized by symptoms of sadness, feelings of hopelessness, having low energy, suicidal thoughts, loss of enjoyment or pleasure, problems with concentration, appetite. So that's a psychiatric illness, a depression. But it can be caused by many things. For example, endocrine disorders, like thyroid disorders can cause depression. There can be other medical causes. But there's also many psychosocial factors, like losses of jobs, relationships. And in many cases, they are just unknown why people develop these signs and symptoms. But the illnesses are classified by signs and symptoms and not really by what's known to what's going on in the brain, even though there's been a lot of work to try to understand networks that, are associated with these disorders. But that's really the guts of psychiatry, and it's been really that way for the past 150 years. And even though they've modified it based upon, research, the core principles are the same. So there is the brain involved though. And so neurotransmitters were first discovered in 1936. Well, that's when the Nobel Prize was given. And the first neurotransmitter that was discovered was acetylcholine. But there's been other neurotransmitters that have been discovered, and these have been, in some cases, then the basis of medications. In 1942, lithium was discovered as an effective treatment for bipolar disorder, and chlorpromazine in 1952 was the first medication which was really shown to improve the outcome for schizophrenia. So that kind of, so you can show that the brain is involved in these psychiatric disorders, because often these medications will affect the course of the treatment. Now in the 1980s, neuroimaging developed, and I'll talk about that a bit, but I'll let Dr. Hutchison talk about it more. But there's been a lot of work since the 1980s using modern fMRI and other technologies to try to get at, what is going on in the brain when people are having these behavioral disturbances. Now I'm just going to mention psychology because that's also an overlapping field. That's also a field that studies mood, cognition, behavior, and emotions, and it's made many substantial contributions to the field of mental health. However, it tends to focus more on the full spectrum of behaviors, including normal behaviors, and it doesn't take quite the same medical model approach of trying to come up with specific diagnoses, and tends to focus more on behaviors as being part of a spectrum. And in a general rule, psychiatry is focused more on medical interventions, primarily medications, but also other things that affect the brain, like electroconvulsive therapy, more recently, transmagnetic cranial stimulation as examples. And I'll get into that because that actually is a newer technology that tries to target specific brain circuits, even though, again, specific is kind of a loose term in psychiatry because it's kind of a loose field to some extent. So there's been a huge amount of growth in the literature of brain circuits and neurotransmitters involved in psychiatric disorders, but our understanding is still very incomplete. And so, as an example, psychiatric medicines are known to act on specific receptors. Serotonin reuptake inhibitors like Prozac being one example, and they can be shown to improve the outcome of depression. However, the effect on the receptors is immediate, whereas the behavioral effect usually takes weeks to develop. So the one area where there has been a push in the last really couple decades to try to focus more on, hitting specific brain circuits involved in mood and cognition. And I think that really transmagnetic cranial stimulation is the one that really does try to target specific dorsolateral prefrontal cortex, which is a part of the brain region. And what it does is it uses magnetics, like magnetic fields, to induce electric currents. And this has been shown to relieve depression, and it works about as well as changing medications. However, again, the exact mechanism by which this relieves depression is still unknown. And I think it's really a limitation of the technology and our ability to measure really what's going on in the brain at these really rapid levels and translate that into clinical understandings in psychiatry, at least, still has quite a ways to go. This is a picture of the brain, and I'm sure you've seen this, but the dorsolateral prefrontal cortex is sort of in the front, and that is like an area that's then targeted by these, transmagnetic cranial stimulations, which they induce electric currents in those parts of the brain, and that's really the first area where I think a specific circuit is targeted in order to achieve like a clinical remission. So I guess as a general overview, most brain imaging studies nowadays that study the relationship between brain and behavior, they don't just focus on one brain region. And there's really now been a focus on understanding networks, and in fact, networks of networks, which is really how different brain regions are communicating with each other. As a general rule, though, all psychiatric disorders are thought to be linked to disturbances in brain-based systems that regulate behavior. So, and that, for example, I mean, this is sort of a simple example, but anxiety disorders, oops, I gotta go back, are thought to be related to a basic system of fight or flight systems that are necessary for survival. So anxiety, if you get nervous about something, that will focus your attention on certain key stimulus. But this system can get overwhelmed. So for example, if you repeatedly are exposed to traumatic events, that anxiety system can become sort of hyperactive. And it's thought to then, that you sort of re-experience traumatic experiences, and you overinterpret minor stimuli as signaling a dangerous situation. So that's something we might call post-traumatic stress disorder. Now I'll let Dr. Hutchison talk about addiction, but substances of abuse can have a rewarding effect. However, with repeated self-administration, your brain adapts to them, and that can cause you to need to use more to achieve the initial effects. And eventually you might experience withdrawal symptoms when taking the substance, thus leading to an addictive disorder. And this is all, there's really well documented, mainly in animal work, brain adaptations that occur, for example, with substance use. And in fact, the fact that the brain's involved is people can get life-threatening withdrawal symptoms. And I'm just going to end this then on, this is a picture of a brain on cocaine and in comparison to a brain in saline. And what you can, the main point is here, there's a lot of red little blobs in this brain on cocaine, which I think is dopamine signaling. But the basic point is these psychiatric disorders, there's brain regions all over the brain that are being activated, in this case by substance abuse. But in the case of most psychiatric disorders, in imaging studies, you can see multiple brain regions being activated and in fact interacting with each other. But right now, the technology to turn that into kind of a clinically actionable understanding is still pretty limited. And that is my 20-minute highlights of psychiatry.
Great. Thank you, Dr. Hopper. I think we'll go ahead and move right into Dr. Hutchinson's talk and then take some questions at the end.
Great. I will share my screen. Thank you so much for the introduction. And thanks, Christian, for setting the stage for the focus on addiction here. So hopefully you guys can see the slides here. And so, yeah, my job is to talk about addiction. And so let's just jump right in here and we'll do a quick overview. So what is addiction? Well, addiction is a brain disease. And, you know, Christian alluded to this earlier, Dr. Hopfer did. And how it's characterized basically is by compulsive behavior. People are compulsively taking the drug. They continue to take the drugs despite negative consequences. So maybe they know it's bad for them. They know it's bad for their relationships. They know it's bad for their work. It's bad for their health. But yet they still continue to take the drug. That is, one of the signs of addiction. And then on the neuroscience level, that is accompanied by persistent changes in terms of brain structure and function. So, another piece of this, if you just think about it outside the neuroscience for a second, is that, people begin to take the drug. They start taking the drug because it feels good. But later, they're taking the drug to avoid feeling bad in terms of when the drug is not there. So, okay, so this is an interesting slide here in terms of addiction. A lot of times when I teach a course, I'll ask my students just to vote. What do you think the most addictive substance is, right? And I'll give them like 5 choices, nicotine, cocaine, crack, marijuana. Well, I'm cutting the chase here. Instead of asking you the question, I'm just going to show you the data here. There was some research done, a survey basically asking people about how they view the drug. And, what they basically said was the most addictive, according to experts, the most addictive substance is nicotine, followed by crack and crystal meth and alcohol, heroin. You go down the list here, what you see basically is that there are some things you obviously would think of as less addictive, things like marijuana and psychedelics. So how does addiction develop? So we're going to sort of lead in now into the neuroscience of this. So there are a couple of important pieces here. One is what we call reward, and also then the brain circuits that underlie reward. Another way of looking at this is incentive sensitization. So what happens basically with this reward network is that things that signal reward, things that have some incentive value, they basically become more and more powerful. And that things in the environment that are associated with those drugs, right, those rewards, are able to trigger these circuits. So there's this reward network. There's also a control network in the brain, where basically you lose the ability in the control network. Normally it controls the reward motivation circuits. But what happens is that control network also changes with time with repeated administration of drugs. So, we talk about different drugs of abuse. They all have these sort of similar effects on these systems. And for me, a lot of my research has been on alcohol. Alcohol also affects both these systems. So let me just show you the brain here and what we're talking about. So here what you see is 2 figures, figure A and figure B. And figure A is showing you the critical circuits in the brain that are involved in addiction. the prefrontal cortex, orbitofrontal cortex, nucleus accumbens, which is the reward center of the brain, also the amygdala and hippocampus, which stores a lot of information about these cues and how they're associated with reward. So those are the main sort of connections and the main structures in the brain. And then down here, what you see is in figure B, panel B here, is sort of the non-addicted brain. Like, how do these things usually work? Well, how they usually work is that you have some normal connections here between memory centers in the brain that are associated with certain cues that signal reward and salient. So normal rewards like food, sex, things like this. These are important for humans, right? And so these connections work normally, and that's connected with a drive and basically a signal to acquire some reward or not acquire some reward. And there's also this control sort of network up here that's involved in self-regulation. Basically, it's regulating this drive for reward. The problem is in the addicted brain, when you directly stimulate these different structures in the brain with drugs like cocaine or meth or whatever, alcohol, nicotine, you get this powerful connection right here between parts of the brain that are involved in memory and the part of the brain that signals salience or reward. And then what happens is then, that drives very powerfully this compulsion, the drive to use the drug, right? At the same time, you see over here, you have more powerful control, more powerful self-regulation in the non-addicted brain. At the same time, there's a diminishing connection here between the parts of the brain that regulate involve self-regulation and control and this drive, right? So basically, we've mapped these different behavioral aspects onto these different parts of the brain. And we know now how these circuits are changed as addiction develops. And this is not just for one drug, it's for a number of drugs. However, the degree to which this happens is different for different drugs. So in my previous slide, you saw, nicotine is very powerful, methamphetamine, cocaine, right, in terms of driving these changes, alcohol, but things like psychedelics, and cannabis less so. Okay, so this one slide really, I think, is in a nutshell, that is the neuroscience of addiction. So let's talk about for a second, we're going to focus on three drugs. There's a lot of drugs we could focus on, but this is a quick overview, right? Let's talk about alcohol, cannabis, and I'm just going to say a couple words about opioids because, of course, it's such an important societal problem right now in terms of opioids. So let's talk about alcohol for a second. So alcohol use disorders, it's the most commonly used drug out there. Some people are, I'm sure, familiar with this, and maybe some less so. It's an important societal problem, right? So it has big implications in terms of health, in terms of the lives of people in general. So it's estimated, and this is actually old statistics here, but more than 32 million people are affected by alcohol use disorder in the US. However, only about 7%, 8% of people will actually seek treatment. So an important thing to note here is that alcohol use disorder actually impacts more people than any other substance or mental health disorder. Now, also, according to the CDC, around 80,000 people die each year from alcohol, right? Alcohol-related deaths. So it could be direct alcohol poisoning, it could be car accidents, things of this nature. But 80,000 people, and that's the number that the CDC basically, ascribes to alcohol use disorder. So let's just talk about cannabis use disorder for a second. It's a little bit different. And actually, I chose a slide here that gave you both, marijuana use and a hallucinogen or psychedelic use. And the thing is, when you look at cannabis use disorder, it's hard to find the same statistics because cannabis use disorder does not kill 80,000 people a year. It has its own issues, it has its own problems, but it's not on the same level as alcohol. So this just shows you how, use has been increasing, especially among young adults over the years, and both for marijuana use and for psychedelic use. And again, I include this because, of course, in Colorado, we obviously legalized cannabis 10 years ago. And of course, in terms of psychedelics, that has also been increasing in both in terms of the acceptance or legality, legal status of it, but also in terms of, in terms of use, especially among young people. So these are two important things to watch, and with respect to increasing use among young people and what the consequences or implications might be. Okay, so I'm going to just move on now, talk a little bit about our research, essentially comparing the effects of cannabis and alcohol on the brain. This is a little bit, this goes back to 2016, 2017, but we had an opportunity to actually put a lot of people in the MRI. So we can look at the brain, we can look at gray matter, so we can look at the density of neurons in the brain, we can look at white matter, so how basically how communication takes place in the brain, and we can ask a question about, well, what is the impact of long-term alcohol use on gray matter and white matter in the brain, on neurons in the brain, and what is the impact of cannabis use, right? And so I had worked for a while in New Mexico, basically collecting a lot of brain data on adults and adolescents. So, close to 1,200, 1,300 people we scanned down in New Mexico. And so we had basically, a subset of adult users and adolescent users. And we were able to look at who used both alcohol and cannabis. We were able to basically break that apart and analyze the effect of alcohol while controlling for cannabis, and then flip it around and ask the question about how does cannabis impact the brain while controlling for alcohol. And of course, they're commonly used together. So sometimes it's hard to tease apart, but that's what we were doing with our statistical analysis. So I'm going to give you the snapshot here. So if you ask the question, what impact does chronic alcohol use over many years, what impact does it have on neurons, on gray matter density in the brain? What you see here in the blue is basically where you see a reduction in gray matter associated with long-term alcohol use, right? So, and this is like well known. A lot of people have looked at the effect of alcohol use in the brain. And over time, over many years, because of course, alcohol and cannabis use both start in adolescence. And so, of course, you can imagine if you start drinking heavily in adolescence, that continues through, midlife, through the aging process. And there are many years then of exposure to alcohol and or many years of exposure to cannabis. What we see is that alcohol has a pretty significant impact in terms of reducing gray matter in the brain. When we look at cannabis, we don't see the same effect, a very different impact in terms of gray matter in the brain. When we look at white matter in the brain, and so we see essentially the same thing. White matter integrity diminished substantially over years of alcohol use, but no similar effect in terms of cannabis. We also looked in adolescence because, of course, in adolescence, the brain is still developing. It's a critical period. Adolescents are vulnerable to the effects of alcohol and cannabis. So we asked the question about whether we see any changes in gray matter or white matter in adolescence. And the truth is, for alcohol, not a big difference, or no significant differences really for alcohol or cannabis, which is not surprising because, adolescents have only been using alcohol or cannabis for a few years when we captured these data. With white matter, we see just a tiny bit of differences in terms of alcohol and no effect for cannabis. So again, not a lot going on with adolescents yet, right? But again, over the course of many years, substantial changes in gray matter and white matter with alcohol. So another question we had about this is, well, what about older adults? Another way to look at this is we can take people who are over the age of 60 who've been using cannabis for many years. I mean, Willie Nelson is an example of this, right? And we can ask the question about, well, are they different than people who have not been using cannabis for 30 years, right? So we did that also. And so we looked at their brain morphology, we looked at the gray matter, the white matter in the brain. We also did some cognitive tasks to see how they were doing. This is a graduate student of mine. But basically, what we found, which is very interesting actually in some ways, because we didn't find anything. We found very few differences in individuals over the age of 60 who use regularly their whole lives versus those who didn't, right? You see these different brain structures here, basically no differences until you get to the reward center of the brain, right? And in the reward center of the brain, we actually found that people we actually found that people had greater gray matter, not less, but greater gray matter if they were smoking cannabis in areas like putamen and potentially other reward structures in the brain. So, so this is another slide here showing you when we talk about regular users who were over age of 60, they were actually, some of them were very, very regular users who were using, you know, basically almost every day, right? So this is, I think, a good test of what happens or what does it look like when people are smoking or using cannabis very regularly into their 60s. Okay, so the summary here, yes, both alcohol use and cannabis use. These are two examples, well, actually almost all examples, right? I mean, adolescence is when people start using alcohol and drugs. So that's an important, you know, thing to remember. This is a chronic kind of a problem that originates in adolescence and potentially goes through the lifespan. So, however, comparing the two, alcohol abuse clearly produced pretty profound changes in the brain, and cannabis use didn't produce the same kind of effects. Now, it doesn't mean that cannabis doesn't produce any negative effects. It just means it's not the same kind of obvious changes that we see with alcohol, right? So, you know, we're limited in terms of what we can look at. It's possible that cannabis produces more subtle effects in the brain over time, and some of those could be negative, but clearly alcohol produces profound changes over a lifetime of alcohol abuse. Okay, so one important point here too is that cannabis is fundamentally different because the endocannabinoid system, so the system in the body, basically we all have a system in our body that has receptors that basically can respond to the use of cannabis, right? We have already in our body endogenous internal sort of cannabinoids that are sort of important functions in the body, right? The interesting thing here, though, is that that system changes dramatically with age. So it peaks in adolescence, and then it basically goes down. And when you're something like 50 years old, you have about 50% of the receptors, right? That, for example, THC binds to. So there are big changes in the system over time. And also, what that suggests, of course, is that maybe there are big changes in the risks and benefits over time. So you can imagine if you have an abundance of receptors, your endocannabinoid system is really, you know, responsive when you're younger. That could basically, you know, suggest that you're potentially more at risk for problems that could develop or be associated with cannabis use. Obviously, then if you know when you're 65 and your system is quite a bit different, maybe you're less likely to be prone to the negative effects, and maybe, who knows, you know, potentially the risk benefit ratio is different, right? So that, I think, is a very important thing, because of course what we see is that in adolescence there are definitely some risks there for cannabis use, right? So that may be partially a result of how the system is different in adolescents versus older people. Okay, so that's the cannabis part. I just want to talk about opioids for a quick minute. Obviously, it's in the news all the time, right? We have an opioid problem, and so this is like some of the basic stats here in terms of the number of people who have died. You know, for example, in 2019, over 70,000 people, and people who misuse prescriptions, 1.6 million. And so this has been a big problem. And, you know, they've sort of looked at this now as like 4 different waves of opioid use, right? The first one being, you know, 1998, 2010, a second wave, 2010 to 2014, a third wave here, and then we're kind of in the middle of this 4th wave, especially now with fentanyl and other, you know, synthetic opioids. It's obviously a huge problem. It's been a huge increase in terms of deaths per 100,000 people in the population, dramatic increases, right? And so, yes, this is a big problem. You know, in the beginning, a lot of it originated from prescription opioid use. In recent years, we've clamped down on that, and that is less likely now to produce the same problem. But still, obviously, we have a ever growing problem now with fentanyl and other opioids. So, okay, so I hit on 3 of the things. I've only got 20 minutes. I've got like 1.5 minutes left. So what research are we doing now? Basically, we're interested in and actually using cannabinoids, and not necessarily THC, but using cannabidiol. How can we use cannabidiol to basically potentially as a treatment, for example, for alcohol use disorder? And this is a study we're doing right now where we're looking at cannabidiol as a potential treatment for alcohol use disorder, because we know that cannabidiol is anti-inflammatory in the liver and the brain. It may have some positive effects because alcohol is actually inflammatory. And also there's some evidence to suggest that cannabidiol might reduce craving, which also is helpful for people with alcohol use disorder. So we're doing a trial now. We did an early trial to begin with, just to see what would happen. We did get some signal. This is looking at cannabidiol, full spectrum cannabidiol from hemp, compared to broad spectrum, compared to placebo, and showing that we see a diminishment of craving in the full spectrum condition, a diminishment, a reduction in alcohol severity, use disorder severity, and some other alcohol use disorder measures. So in our initial study, we saw some positive signal. Of course, a very small study. So now we're following up with a larger study to see what we can see in terms of the effects of alcohol. The effects of cannabidiol in terms of alcohol use disorder. We're also doing a study on chronic pain and opioid use disorder. Similar kind of thing. There's some suggestion that cannabidiol might be important for reducing opioid use, opioid craving. And so the thing is, we're right in the middle of the study. So no, we don't know yet whether it's working or not working. I think in another year and a half, we'll have sufficient data to answer that question. And then finally, we're also looking at cannabinoids in the context of aging and dementia. And, this is, again, the problem, of course, is that the popular press runs with these ideas, right? Like that, I took a photo of cover from Discover magazine. This was like a few years ago, and they're claiming a surprising impact on dementia and other health issues. And so we're checking that out now too, in terms of looking at how that might impact dementia and just in general functioning for our seniors who actually have been taking more and more cannabis as compared to younger people. The increase in cannabis use among seniors has increased dramatically with legalization. So it's very important to understand whether that has potentially a negative effect, or there's some positive effect that we just don't know. Okay, so we're doing a clinical trial on that as well, and hopefully we'll have some answers on that soon. Also, we have a center now looking at basically cannabidiol in the context of harm reduction in terms of reducing THC use, and also looking at across the lifespan. So I'm going to stop there. I'm a minute over, and I'm going to basically hopefully some time for questions.
Okay, well, thank you very much. We've got some time. In fact, we've got about 15 minutes, which is great for questions. I'm going to turn it over to Tammy.
Okay, so the first question is, how do you apply TMS? Is it external or internal or surgical? And is it available to the general public, or is it still experimental?
It's applied externally. It is available. It's a FDA-approved treatment. The CU Depression Center has it. I think you do, it's typically reserved for people with treatment-resistant depression who have not succeeded with sort of standard psychotherapy and medications. But a patient of mine recently had it and had a positive response to it. She did say you get this sense of like clicking in your brain. It's a very strange experience, but she did experience relief from her depression, and it is available. It's an FDA-approved treatment for depression, and we have it at CU in the psychiatry department.
Is it covered by insurance?
Okay, I'm not an expert on that. I suspect you have to have failed multiple previous treatments. That would be my guess.
I might add to that the energy used by it's a little probe that goes, just over the surface of the scalp, but it's very much like having an MRI scan, the electromagnetic force, but it's very concentrated in an area. So it's like having an MRI that, that's focused.
Can drugs like cocaine cause hallucinations or a person to lose their sense of reality if they abuse it?
Right. So I think in general, that's a possibility, right? And perhaps not a common thing, but definitely a possibility. I don't know, Christian, if you want to weigh in on that.
Yeah, I mean, coke, if you do enough of it, will definitely make you paranoid. Really fully dissociating is less common with it. That's more common with maybe meth or PCP or like hallucinogens. It's not as common as coke.
Why, at the beginning of the talks, you talked about psychiatry, neurology, and psychology all being called an alienist.
Oh, that was an old term for psychiatrists. I thought it was sort of an interesting old term.
Do you have any sense of why that term was
Why it
used?
changed? I don't know why they used that term. Yeah, the labels kind of changed over the years.
Okay. Next one is why in one of your slides it showed that there's been a big jump in heroin use. And the question is, do you know why?
So in general, I have to go back and look at the slide in terms of the jump in heroin use. I mean, in general, I think we're very concerned about the large jump in opioid use broadly, right? Especially recently, right? So I'm not sure exactly which jump or where they're talking about, but looking at those figures, the real change in the slope has been in more recent years with all opioids combined, and especially recently in terms of some of these super potent opioids.
Yeah, I'll just say heroin, can't even find it anymore. It's all like become fentanyl in the drug supply. Fentanyl is an extremely powerful opiate, which is about 100 times more powerful than heroin. And it's very easy to smuggle because you only need small amounts of it. You don't need to grow it, you don't need poppy. You can literally manufacture it in a factory. And I think it's just become a very, but essentially what happened is drug cartels have just decided they can make more money selling it, and it's much easier to smuggle. And I think it's just essentially swamped the drug supply, and it's so potent that people overdose on it more because they just have trouble estimating the dose effect.
Can you speak a little bit about hallucinogenics and their effect on various psychiatric disorders?
This is a popular topic. And I think it's a topic that deserves more research. Now, psychedelics have been around since the 60s. And if they were a miracle cure for mental illness, we probably would have figured it out by now. But it does seem that, the data is that when psychedelics are combined with specific psychotherapies, they have been shown to improve outcomes in a variety of psychiatric conditions. However, all of those studies have what are called expectation effects. And in psychiatry, there's a very strong placebo effect. So if you come into treatment and people pay attention to you and you are told you're going to get better, often people will get better for a while. And I think right now there's a need for larger, more well-controlled trials. It's certainly a promising area. I think, again, if you've been around in psychiatry, there's fads. and I think it's worth exploring. Our department's exploring it. I think it's worth exploring. Ken, you can give your opinion on that.
No, I think you covered it really well. I think it's definitely worth exploring, but there are some methodological issues, right? So we're very interested in it, right? And I think, but it's going to be difficult to sort of tease apart expectancy effect from the real effect, and but we need to do that work, right? So yeah.
Okay. Can you speak about heredity and psychiatric disorders? For instance, which disorders are most often associated with heredity, excuse me.
Well, okay, there are 2,000 known genetic mutations which are known to be associated with developmental delays. So that's well established. So, I mean, children who have developmental delays, there's a lot of rare genetic mutations that will usually involve big chunks of chromosomes missing or being in different spots. And that's kind of well established. Most psychiatric disorders have a component that's considered heritable, but it has been very difficult to find specific genes that cause those disorders. There are some exceptions. There's in East Asians, they have a mutation in the gene that affects their ability to consume alcohol. They tend to get a flushing reaction when they drink alcohol, and it turns out if every time you drink alcohol you don't feel well, you tend to have a lower rate of developing alcoholism. So that's a well-known projective effect, and it's a pretty big effect. There are a few rare genetic conditions that cause psychosis that have been studied, but for most psychiatric illnesses there's like a component to it. But, I've been involved in these studies where, you cannot find single genes or even genes of modest effect. The effects of individual genes is very small. If you add them all up, you could still have trouble making much of a prediction. So that's been unfortunate. When I got into the field, I hoped by now we would have had the genes for schizophrenia, and we would have been developing medications or reclassifying things. But it's just more complicated, and that's an area where there's still a lot more work to be done. But it's definitely not. There's no genetic test for any of these psychiatric.
The last question we have is, how many faculty does the Department of Psychiatry have?
500, 600, a lot. Most of them are treating patients.
Okay. Any last words from our speakers?
Thank you for your interest.
Thanks for having us on.
Thank you for being here. Okay, Dr. Lillehei.
Yeah, thank you guys very much. I guess I have one more question. I just wanted to re-emphasize for the audience the difference between psychology and psychiatry.
Yeah.
And you guys are all one department, obviously.
We're one department and we love each other. I mean, psychology has done a ton for mental health. It tends to it's got less of a medical model approach. I think that's a fair statement, but I think it has a more dimensional view of a lot of these behaviors, which is probably more accurately reflects the data. And it tends to focus less on severe mental illnesses like schizophrenia or bipolar, where there tends to be more of a medication component. But they've done a lot of the research in the brain and the basic brain mechanisms. Ken, what do you think?
I think it's true. It's a more less of a medical model in psychology. However, when it comes to I think a lot of the differences have to do with the clinic, right, and seeing patients. When it comes to research, I feel like we are more aligned in some ways. So yeah.
Yeah, research-wise, there's not that big of a difference. Clinically, psychologists do more testing and psychotherapy, and psychiatrists have actually sort of ended up mainly writing medications.
Okay. Well, thank you both very much.
Yeah.
So we've got a little bit of time left, and this is great because this is our last of the 6 sessions that we have in the Brain 101 mini medical school. We want to first thank all of our people that have gone through this whole course and listened to all the different lectures. Tammy again will be distributing the recording from today's lecture, but more importantly, we'd like to get a lot of feedback from you all. We'd like to do this again. I think it's we've had a lot of fun, but we've had a lot of positive feedback from the group. So we'd love to hear exactly what people would like to hear when we do this again. And I think our plans, Tammy, you can speak here, maybe doing it next year again. As our
Yeah, we're talking about doing it again, probably in the spring, or maybe we'll skip a year and do it again. But I will be sending out all of the recordings. We did have a few more questions that came in right at the end, and I will make sure we get the answers to those, and we'll send them out to you like we always do. You'll get your certificates, and we will also be asking you for feedback. What kinds of topics would you want us to cover the next time? What didn't we do that you wish we would have done? What did we do that you liked? Those kinds of things. So we'll get those to you here in the next few days.
So again, thank everybody and thank our two speakers today. This was terrific. Thank you very much.
Yes, thank you so much. And thank you everybody for participating.